Good evening. On behalf of myself and Dr. Mintz and myself, we would like to welcome you to the National Lipid Association's The Lipid Panel. My name is Merle Meyerson, and I'm a cardiologist and lipid specialist, as is Dr. Mintz. The Lipid Panel was conceived to be a lipid clinic conference similar to educational conferences held at academic medical institutions. For both those who have these conferences and for those who do not have in-house conferences and colleagues, the Lipid Panel is a great way to review diagnostic approaches, how to interpret clinical findings, and generate therapeutic strategies. Find out the most up-to-date information and come together with those in the lipid and cardiometabolic community. In this series, we will review common presentations of rare diseases, atypical presentations of common conditions, and sometimes even common presentations of common conditions. And we will try to cover as many important clinical topics every lipid specialist needs to know. If you have thoughts about topics to be presented, please be sure to let us know. I'd like to introduce our panel tonight. We have Mary Catherine Cheeley, is a PharmD and Executive Director of Ambulatory Pharmacy Services at Grady Health System in Atlanta, Georgia. Dr. Cheeley is a graduate of Mercer University, where she earned her doctorate of pharmacy degree and a primary care pharmacy residency at Grady. She oversees 13 retail pharmacies, as well as the clinical pharmacy medication access and medication adherence programs. Salman Hasham is also a PharmD and is an ambulatory care clinical pharmacist at Grady Health System in Atlanta as well. He received his Bachelor of Science degree in biology from Georgia State and received his Doctor of Pharmacy from Mercer University, as well as his residency at Wellstar Atlanta Medical Center. He is currently practicing in the cardiology clinic, including advanced lipid clinic and heart failure. Dr. Joe Saseen is very well known to all of us in the MNLA, a clinical pharmacist and academic leader. He's Associate Dean for Clinical Affairs and Professor of Clinical Pharmacy and Family Medicine at University of Colorado Anschutz Medical Campus. His expertise is centered on cardiometabolic disease with a particular focus on dyslipidemia. And he's past president of our MNLA and a contributing author to the 2018 Multi-Society Cholesterol Management Guideline as a member of the upcoming 2026 Guideline Writing Committee. Bruce Warden is a cardiovascular pharmacist, also a PharmD, at the Center for Preventive Cardiology, Knight Cardiovascular Institute, Oregon Health Science University in Portland, Oregon. He received his PharmD degree from the Oregon State University, OHSU, and completed 1 year postgraduate pharmacy practice residency there as well. His clinical practice area is cardiology, including preventive cardiology. Clinical research interests include atherosclerotic cardiovascular disease risk reduction. So with that, I'm going to turn it over to our presenter, Dr. Hasham, if you'd like to begin with our case. Thank you and welcome to the Lipid Panel.
Thank you, Dr. Meyerson. So today good evening, everyone. Today we're going to talk about statin intolerance. So just to get everybody, juices flowing, we want to start off with an audience response question. So the first question we're going to ask is, what is the minimum number of statins that a patient has to try and fail to be classified as statin intolerant? And the answer choices are A, 1, B, 2, C, 3, 4, D, 4, and then E, I don't know.
Good. It looks like we have a few answers in already. The majority looks like somewhere between 2, failing 2 statins to classify as statin intolerance, just over 53% of the audience response, but also some saying 3 and scattered for 1 and 4 as well. And I think maybe that's an important concept we can bring up, is what guideline or document are we discussing when we're talking statin intolerance. Dr. Cheeley, you want to comment on maybe what you turn to for guidance on that particular area?
Yeah, I think from The NLA has great paper on this. I might be a little bit biased on it. It was great. It was a great experience that Joe and I had updating the definition. But I think our definition goes through a novel part of that, which is complete and partial intolerance. But we do talk about it as 2 statins, 1 at the lowest dose, and we'll kind of go through that a little bit as we go through our case as well.
Great.
All right, so today's case is an interesting one. So we have a 68-year-old African-American female, past medical history of CAD, status post-MI, which was about 5 years ago. She had a CVA about a year ago, peripheral artery disease, obstructive sleep apnea, hypertension. As far as her family history goes, her father had a stroke in his 70s. Mother has hypertension. As far as the labs that are pertinent, her highest LDL has been 161 milligrams per deciliter. Her LPA was 191, and that's in nanomoles per liter. Imaging-wise, she had a CV coronary angiogram. The RCA showed chronic total occlusion, and then the previous stent of the mid-RCA visualized, as well as the OM1 showed 40 to 50% stenosis. She was a former smoker, 32-pack year, and she quit after her MI. Alcohol-wise, she drinks a glass of wine occasionally during holidays. Some of the relevant medication that she's on, those are amlodipine 5 milligrams daily, hydrochlorothiazide 25 milligrams daily, aspirin 81 milligrams daily, isosorbite mononitrate 60 milligrams daily. And as you can see, there's no statin in this medication list. So patient did report statin intolerance with statin-associated muscle symptoms. So we got another audience response question here. So what are some risk factors that can potentially predispose a patient to being intolerant to statins? So the answer choices are hypothyroidism, obesity, alcohol use, smoking, or all of the above.
Okay. So looks like the majority stated all of the above, with the second most common being hypothyroidism. So definitely hypothyroidism is one that comes to mind as a screening as a secondary factor. Weight management, and anyone please chime in. I typically see it on the opposite end, where it's more of the lower weight cachectic patients that are more predisposed, lower muscle mass, less likely or more likely to have issues with potential statin intolerance. Substance abuse use, I can definitely see increased risk, particularly with alcohol. Not so much with smoking from my perspective, and I actually think of smoking as being more of a CYP enzyme inducer, so it would actually reduce the levels of our statins. But I don't know if anyone else views smoking as a potential risk factor from the group.
Yeah, and I mean, hypothyroidism jumps out at me clearly, and my experience has been the more frail elderly or older, smaller body weight person is probably more likely. I think the alcohol is tempting. If it said alcohol abuse, that might be different on liver disease, but just alcohol use, heck, that was me.
I will say for obesity, I see that as a double-edged sword, because we have patients who are obese that then get really motivated and want to start working out. And so they do have increased physical activity, that is the risk factor, is the increased physical activity. But I do think that at least some of my patients, yes, low weight, older patients, but my obese patients still are having some intolerance.
Yeah, that's actually excellent insight, and will be something that maybe we'll discuss as we move forward with this. But changes in lifestyle patterns, whether that's exercise, substance use, anything of that nature, I think obviously is an important risk factors to consider. Great.
So continuing on the case, so patient follows up in Lipid clinic today with the clinical pharmacist. Patient reports statin intolerance with statin-associated muscle symptoms, and you can see that she's used 3 different previous statins. So she had rosuvastatin 20, and that she took for about a month. Atorvastatin 40 took for about 2 months. She had muscle aches and cramps with both of those medications. And then pravastatin a few years later, she took for about 3 months, and she had muscle aches. Her current LDL is 141 milligrams per deciliter. Her fasting triglyceride is 148 milligrams per deciliter. A1C is 6.3. Patient today is willing to retry statin.
Great. So I guess the question becomes then, is this actually true statin intolerance? And one thing, actually, if you can go back to the case real quick,
Yeah.
so we can take a quick look. When the patient discontinued the statins, do we have any information as to whether or not their symptomology changed and in what time course?
Yeah, based on a chart review, it did say that, once she did stop the statin, a few weeks later, her symptoms kind of decreased and started kind of going away. But that was chart review. Once we talked to the patient, she wasn't, she didn't know too much about it because it was such a long time ago. But she did say that with the pravastatin, for sure, that it did completely go away within a few weeks after she stopped.
Great. Okay. Let's go ahead and advance. So let's discuss this then. Next one. Great. So I think defining what is statin intolerance.
Yeah, this is what we're talking about before. So one or more adverse effects that are associated with the statin use. So again, we don't know if it's causal, but associated. And then it resolves completely, or at least reduces when the statin is taken away. At that point, we need to make sure, again, true statin intolerance is a minimum of 2 statins tried, 1 at the lowest approved dose. So for this patient, she has not been on the lowest approved dose of a statin. So by definition, she is not technically statin intolerant. Although I think any of us as clinicians in the clinic with her are going to treat her with kid gloves. We're going to make sure, hey, we've tried 3. She's giving us a 4th chance. I'm going to say this is probably our last chance with her on this statin. Salman is wonderful. I've been in clinic with him, so maybe he might get a 5th, but we need to make sure that we're really kind of picking our battles here with this lady. And then past that is when we can think through complete intolerance or partial intolerance. Joe, we had many conversations about this in our working group. I think this was one of the, honestly, the most pivotal things in the definition that we talked through.
Yeah, I mean, I think this is reality, right? Partial intolerance is better than, complete intolerance.
Absolutely.
Because a little statin's better than none. Unfortunately, when I saw in this lady that pravastatin 20, which I don't consider a very impressive statin. It's low intensity. That was associated with muscle symptoms reported by the patient. That was disappointing because that's actually pretty weak. I would have much rather, ideally, tried just a lower dose of atorvastatin or rosuvastatin, but you can't always have your luxury with some of these patients. You got to try what is best for them. And the one thing that is really just jumps out is it doesn't matter if we think it's associated, if the patient associates it. And I struggle with that word statin associated because it should be statin attributed, right? Because the word associated implies a cause and effect, but it's the world we live in. So if the patient experiences it, even though we may not be convinced, it's something we have to deal with, and it fits into the definition of intolerance.
Yeah.
And I want to chime in here real quick. These are excellent points because we get this a lot in clinic, right? We have this patient in front of us. But if we look to our guidance with the data, right, the randomized controlled trials, or even our N-of-1 trials like Samson or Statin-Wise, they paint the picture that true statin intolerance is very rare, maybe 1% to 2% of placebo-corrected patients would have a pharmacological effect. So induced directly by the actual biological processes that are induced from the statin. How do we then put that into clinical practice where obviously the percentage of patients we're seeing that are presenting with this is much greater? How do we reconcile these two different concepts?
Yeah, I think that's where that discussion and relationship with the patient is really important. That's why I say, with this lady in particular, we got one more shot with her, because it doesn't matter if you and I know, or if Joe can teach the best lecture ever and tell the patient it is very rare for you to have statin intolerance. They're believing that that statin is causing that problem. They have that nocebo effect. And so regardless, my goal is to get their atherogenic lipoproteins lowered. Would I like for that to be with a statin? Absolutely. But when it comes to what the best outcome is for the patient, I need to make sure that I am listening to what they're saying, gaining their trust, and working towards getting their atherogenic lipoproteins lowered. And that doesn't mean we give up on statins, but it does mean that we need to make sure that we're not wasting time by trying to convince them over and over and over again that they need a statin.
Yeah, I agree with everything you said, and I'm sure this happened because it's a lipid clinic where this patient is seen. Just really, and there's a question in the chat, just sort of where were the muscle symptoms? Maybe educating people of the typical, if there is a typical presentation of what it should feel like, that it wouldn't be isolated to one muscle. It should be large muscles, it should be bilateral distribution. But I actually tell patients that if you're expecting to have a side effect, your brain tells you can influence, and that's not a a shortcoming of them. It's proven. And so I sometimes actually lean into the Samson data and I try to translate it in patient language that if you're expecting to have a side effect, you're more likely to experience it because that's the way we are as humans. And when they know that, maybe if they can gauge somehow their baseline muscle pain, because let's face it, most of the people we're dealing with are not young. And as you get old, you have muscle pain. It happens. And we'd love to point it towards something, and it's easy to think, oh, it's from my drug, but really getting a baseline assessment, an honest baseline assessment might be helpful too. She's willing to try, which is awesome.
Fantastic. Yeah, these are all great. And in our patient case, right? She's a 68-year-old female, post angiography. So we're thinking age-related potentially. We're also thinking, right, changes in lifestyle, as you had mentioned, Dr. Cheeley, right? Increased activity. She's trying to get healthy to prevent further propagation of her atherosclerosis. These are all important concepts.
And real quick, Bruce, I don't want to take too much time in it. She has PAD, and sometimes PAD has symptoms, and she has ischemic heart disease, which isn't really muscle. But some people don't always know.
So many times, I'm glad you said that, because so many times in my patients, they come in and their statin intolerance symptom is lower extremity cramping. I'm like, that's not
PAD.
That's called why you need to be on a statin. So can we maybe flip this around a little bit? But yes, absolutely. And it comes nocturnal cramps. I hear it all the time.
Yes.
But getting that baseline and saying, okay, last time you told me you had it 5 times a week. What is it now? Oh, it's still 5 times a week. Okay, you're right. It's still happening, but it's not the drug that's causing it or making it worse. And I think making sure that we can compare those two together really do help give our patients a fighting chance on the drug.
As we're on this, and I know we want to move on, but an important concept too that I always think of too is being pain-free is not necessarily a reality for most of us, right? As we age. So I always look at how disruptive are these symptoms. I think that's a very important one. If these are mild aches and pains, even if the timeline is associated from when they're switching their statins or starting on statins, we have to frame this in the mindset of, okay, these are not cholesterol lowering drugs. We're not trying to obtain a number. These are heart attack and stroke prevention medications. They can prevent your next stent, add longevity. So we have to weigh the pros and cons to a mild event, mild cramp, a mild muscle ache, to what the potential of this. And I think how we establish that with that patient is very important, right? What are we actually attempting to do?
Great.
Right. So how do we assess statin complaints? And we've kind of started on this already. But this is one of many algorithms that are out there to kind of look at this. But I think an important concept is to really try to get a time frame, as we did in this case. When do they start the statin? When they stop it? Where are the symptoms? The severity of the symptoms, and the timeline of resolution if we modulate that statin or if we remove that statin. And then looking at. Go ahead, yeah.
One thing that I think is, I would love to get your opinion on this, fellas. De-escalate versus discontinue. Do you give a true drug holiday? So in my practice, it depends on the patient, right? Like it depends if they are just, number one, did they already stop it themselves and they gave them their own drug holiday? Or how do you guys how do you do that?
I think it's not a one pill fits all,
Right.
but if there is we should talk about the utility of measuring CK. If CK is rarely, if it is elevated, then I think that's a really good reason to do a drug holiday and to really investigate very deeply. But the harder, more common presentation is muscle symptoms, and the CK is normal, or it's just like barely above normal. And then, I play with the patient. I think that shared decision making is important, giving options. And some people were like, well, it's mild enough, I'll just switch to another one. And other patients were like, I want to make sure it goes away. And so I think I personally would be okay with either. Other things that pop in my mind is do we talk about hydrophilic versus lipophilic? There's a question in the chat that deals with that. I'd love to get other people's input, like not only on your drug holidays, but if you really believe that going from lipophilic to hydrophilic helps out. I'm not, I've tried it and I say it, but I'm not a true believer.
All
Anything
these
I
are
can do to
lipophilic,
convince a
right?
patient, anything that I can do, I will latch on and hold to it.
That's very true. So we had the nocebo effect up there, right? We need to play into that from a positive standpoint too. So whether that's I'm switching you statin, because there's sometimes a negative association with, say, a particular patient, right? She had rosuvastatin. Maybe lowering the dose, there's already that association of I already had a side effect with this drug. Let's try something else. We have 7 FDA approved statins, right? So that's something to play into it. Or you could give a whiff of a statin. There's a question here about giving a statin a few times a week. And now if we're looking at the pharmacology aspect of that, we have to take into consideration things like half-life and plasma residence time and what statins are more appropriate for this. Joe, you mentioned the lipophilicity. All statins are lipophilic, some more so than others. What I find is the hydrophilic statins and lipophilic statins, where they fall into is how they're metabolized. I think it plays more into metabolism. So those that are more lipophilic are more likely to dispose in muscle tissue. Actually, those that are metabolized by CYP3A4, the ones that are more commonly to be used in drug-drug interactions, right? So that's, from my standpoint, that's probably more where the higher risk for some of the muscle symptoms with, say, something like simvastatin or lovastatin comes into play.
I agree. I do think in training and education, I do talk to my students about volume of distribution because you learn about it in pharmacy school, but you don't really understand it or think about it. And so I put those two together with statins to say your lipophilic ones have a higher volume of distribution, means they're getting into spaces a little bit more. And so just because we're all in a teaching world right now, I always do talk about that. I just think that that's one cool thing as pharmacists that nobody ever thinks about, but you can actually talk about it with statins.
Absolutely. I actually use that for the non-statins as well, too. So,
Yes.
right, we have many of our oral medications are what I term dirty drugs. They're going everywhere, right? It absorbs, gets distributed systemically, and that's where that large volume of distribution is. So if we can have more targeted approach, such as things like bempedoic acid, our monoclonal antibodies, our siRNA products, which are more targeted, have a smaller volume of distribution, potentially that may have more targeted effects and less off-target effects at that particular point.
Yeah. Is there anything else we want to cover on this one?
I think the important piece was doing the upfront assessment, and then whether we can do drug holiday switch, make some modulation to their regimen, and then reassess. And then the important piece after that is how dysfunctional, how impaired is their quality of life. If they are having symptoms, what does this look like on the severity of that scale? And are these tolerable? May not be completely adverse effect, but are they tolerable and the patient continue on the medication? Okay, so we'll move on to, so how do we change statins then at that particular point?
Yeah.
And there's no right or wrong way, right? So Joe, if you want to switch the statin, MK, if you want to lower the dose, if we want to give a drug holiday, if we want to give intermittent dosing, these are all appropriate strategies, right? I think what's important to highlight here is, you mentioned just getting them on a whiff of statin to improve tolerability, right? Because we still see good cholesterol lowering with just a little bit of a statin.
Yeah, and this woman, I mean, what's going on in my head is a whiff of a statin plus, because she's going to be a 2-drug person.
Absolutely.
And depending on which one you use, you may need 3 drugs if a whiff of a statin is one of them, unless you use one of the bigger, more potent drugs, because you do have to sort of think about what is the goal in this patient. I mean, I'd emphatically pick less than 55 for an LDL, or the target, or the value to get below, whatever you want to call it. And she's got a ways to go. And so it's unfortunate that we can't use a high intensity statin. I don't think that's an option to go back to that one in her. I think it might just be futile, that she's at best going to be on a little bit of a statin plus non-statins. And depending on which one to pick, you have bempedoic acid with ezetimibe here. That's it's something to consider if we want to get close to an LDL lowering along with a little bit of a statin.
Yeah,
And I
Because
see
your point is that doubling of a statin, it doesn't give you, I mean, we've known about this for a long time that, the 6% rule, which is not that much. You get most of your kick from the first dose, like you said.
Yeah, so in our patients, we have patients who are lower income. So I try to take into account what they already have at home and then either half it or do it once a week or whatever it is, because cost is an issue. And let's call a spade a spade. She's probably not going to tolerate the next one. I don't want her spending a lot of money on something where it might not work. So I try to look back at what they've had before, utilize one of those doses that we can get to. But to Joe's point, I'm not stopping there. I'm not saying I'll see you in 3 months, give this a try. We're gonna do both and try to figure out something else that she can get on.
Yeah, and sometimes these patients present on coenzyme Q10, which I'm sure everybody's been asked that. I'm not a believer that it necessarily works, but I have had people that say it works for them, and then who cares if they're willing to pay for it? I don't think it hurts, but I don't think I'm not sure it helps. I think it helps some people. Maybe it's the opposite of the nocebo effect, right? It's the placebo effect.
It's likely not, it's not harmful. We'll put it that way, right? If they
Yeah.
want to have it in their brain that this is potentially, adding back the CoQ10 that the statin may be depleting, the
Sure.
evidence obviously doesn't make that case from a symptomology standpoint. We can see plasma level changes and even tissue level changes that don't necessarily change pain scores. But if that's a positive placebo effect for the patient, not something I routinely recommend, but if they're wanting to do it and it's not harmful other than, maybe a few extra dollars in their pocket, but
yeah, often these remedies or treatments or things come from a physiologic, source. And so there is a physiologic link between coenzyme Q10 levels going down with statin therapy. And so some of it seems implicit, but you have to really prove it. And I don't feel the proof is really there, but the harm is not there. Another thing that some people, in addition to screening for drug interactions, which has sort of been mentioned already, genetic testing for some of our pharmacogenomic abnormalities, like a mutation, the SLO-CO1B1 or the ABC pathway too, that they're becoming more and more popular to do pharmacogenomic testing. Heck, big academic universities sometimes provide it free if you participate in research. It's called the Biobank. We have that at the University of Colorado. We have got, each institute, I don't know what the experience on this panel is. It's a nice to have available thing, maybe. I'm sort of a little bit tepid on it because we have some guidance. Usually the people that are most problematic, and this is one institution's perspective on it, unless they have mutations in both the ABC and the SCLO 1B1, they probably can tolerate at least rosuvastatin up to 10 or 20 milligrams. I would never use 40. When they have that double mutation is when you really should cap it at 10 milligrams of rosuvastatin or less. And maybe you think twice about high dose atorvastatin. We have not had a huge amount of success in proactively screening patients for this, but when it's available, it's something that might catch my eye. And it does make me think this, as long as you're not going to the highest dose of rosuvastatin, you're probably okay under most circumstances. But is genetic testing common in your spaces? No.
Absolutely not.
Well, patients are coming sometimes with those reports too. And there's like 19 key mutations. Yeah. Oh, yeah.
No.
we practice in different settings.
Yeah, we have a mix. We have everything from very affluential to very, very poor patients who don't have insurance. So the people that I'm likely thinking about, or the people who are bringing the reports, probably do have those resources.
Yeah.
I think
I think Bruce, was this yours? This was a really good point.
Yeah. Actually, this is Joe's slide, which is why it's so good. But
sorry, Joe. All you.
You want me to just, I lean into this just a little bit. This slide can be used and twisted many different ways. This is the Jupiter study data. And if you remember Jupiter, it was rosuvastatin 20 versus placebo in people with high hsCRPs. And lo and behold, great reduction in events, stop study early. But the message here is everybody doesn't respond the same. People are not typical. A typical response for rosuvastatin 20 should be a 50 or more % reduction in LDL cholesterol. But look on the left. Less than 50% of people on that dose of a statin did not get more than 50% of reduction. It was close to 50%. So this message here is that don't count on just looking at adherence or looking at the prescribing pattern to see if you're at your goal. You got to look at the LDL because not everybody gets the same response. I personally believe that most of the power in statin therapy and lipid-lowering therapy is by LDL or LDL reduction, whether you're looking at ApoB or LDL cholesterol or non-HDL, whatever you want. I think that's where the benefit is. And even to the right, I love that if you look at response and plot incidence of events, the people that had the most response had the fewest events. So there's logic in looking at the pharmacologic response, which is the LDL reduction or ApoB reduction, whatever you want to look at.
Yeah, and I see it from another section too, is not only are we achieving the LDL response for that statin, but are we hitting their goal? And then are we doing, as MK was saying, the next addition, the next iteration? There's data, I believe, out of the VA, which shows increased lipid panel checks correlates to decreased LDL and goal achievement. So importance to making sure we're monitoring response, not just for statins, but any of our lipid-lowering therapies.
Yeah, and because we're pharmacists and you guys all came to a pharmacist lipid panel, we would be remiss if we did not talk through drug interactions. So when we were talking about this before, Bruce, you made a really good point about it may not be the drug that they're on right now. It may be whatever was started at the same time as their original statin. And so you do have to dig back through the chart to see, okay, were they on another drug? You used amiodarone before. Love that example. Were they on that before? And that is what precipitated this quote unquote statin intolerance. And then now they've lost all faith in everything. So really important to think through this when you're inheriting a patient who's coming to you in your lipid clinic saying, I can't tolerate statins. I had a bad experience in the past.
Yeah. And this is where we see it is complicated. Drug interactions, it could be hepatic changes from a cytochrome P450 enzyme. It could be a transporter, an efflux, or an uptake transporter. And the OATP B1 1B1 is, pretty prevalent across all statins. That sort of is the genesis of the pharmacogenomic testing for that. But it is not easy to remember all this. And one thing that I like to also highlight is sometimes these aren't as strong as we think. For example, a 3A4 interaction is really, really horrible with simvastatin or lovastatin. But if you look at atorvastatin, requires a little bit of 3A4. It doesn't mean it's as the magnitude of interaction is the same because it's not the same, but there's a little bit involved there. So just looking at this table, it gets so much more complicated because one interaction pathway could be more meaningful with one statin versus another. And it's hard to memorize all these. So you have to look at resources and if you're ever in doubt, just look at what a reliable drug interaction resource says and read what it says. Don't just react, but read, because sometimes it just says a warning. Sometimes it says use a lower dose. Sometimes it says switch to a different statin or switch the object drug to something else.
What would be a reputable source, drug interaction source for?
I personally I use Micromedics.
Yeah, same.
Because it's integrated into our electronic health record. I'm very fortunate with that. But I also like to look at the reporting. They don't just tell you whether there's interaction, they grade it, and then you can click and read the information for yourself. There's other drug information resources. Which is your favorite, Bruce?
I do both. I actually do two. I do Lexicomp. I do Micromedics. I find sometimes there's one that's in one but not the other. But they do a very good job of breaking it down. And I think another thing to keep in mind is the complexity with these drug interactions, because you got to stop and think, well, who are they actually testing these drug interactions? Usually a young, healthy adult. It's usually minimal medication. You're checking simvastatin against amiodarone, right? But when we see our patients, they're on simvastatin, amiodarone, tacrolimus, they're on multiple interactors. So that's where it gets challenging. It's how to put all of these things that aren't necessarily tested in a controlled environment and make a clinical decision based off of that. So just know that many of our patients are probably predisposed to multiple drug interactions at one time. And amiodarone is a great one. Oh, but my patient got amiodarone a month ago in the hospital. Their entire body is saturated with amiodarone.
Yes.
For the next year, they're going to be leaching amiodarone out. So we also have to look at the pharmacokinetics of the other medications that they're on too, because they play an important role.
So I think this is something that, again, we've all kind of hit around, but I want to make sure that we hit this point that statins are great. They are wonderful drugs. We want as many patients on them to be on them. However, not everybody can tolerate them. And so it's really important that you think about your patient as a whole and what your goal of therapy is, because we all want to reduce events, which means we need to reduce atherogenic lipoproteins. And in order to do that, you're going to have to use a different drug. You're going to have your non-statin therapy. You're going to have to think about, did the patient come to you and say, hey, I want to try CoQ10 with supplementation? Or think about other risk factors. So this patient in particular had already quit smoking, but I certainly would talk about smoking cessation in a patient that's this high risk. Or thinking about, is there anyone else in your home that smokes? We need to work on that for them too, because secondhand smoke is also an issue. So thinking through all of that, I think, is really, really important. We would be remiss if we only talked about the statin intolerance for these patients. So take us away, Salman.
All right, so we assessed the patient's baseline muscle symptoms. Didn't really have many muscle symptoms. Just kind of had, PAD symptoms, but nothing else going on. Just kind of her calves were having issues, nocturnal muscle symptoms, but that was it. So we ended up starting atorvastatin 20 milligrams every other day. Now, I know we wanted to start multiple therapies at once, but it's a shared decision making, and the patient was not willing to start multiple therapies, so we kind of wanted to start off with atorvastatin. Patient follows up in Lipid clinic in a month, still reports that she has statin-associated muscle symptoms, and here she kind of tells us she had bilateral muscle cramps or muscle aches as well as weakness. And she discontinued the statin after a month before coming to see us. Reported that all the muscle symptoms subsided after she stopped the statin. So going back to the audience response question. So this is kind of like a pharmacy question and an access question. So patient has Medicare insurance. We want to start a PCSK9 on this patient, given polyvascular disease. The copay for the patient is $150 for 1 month supply of evolocumab. Patient states that she is unable to afford the medication. What should you do next? So the answer choices are: you bill a copay card with the insurance, you investigate financial assistance programs via your foundation or manufacturer, apply for Social Security extra help, start ezetimibe and bempedoic acid in the meantime, or start inclisiran 284 milligrams.
Make it clear to the audience too that there isn't one correct answer. There's multiple answers.
There's one quick thing I want to address from the chat while we're waiting for people to respond to. Somebody asked why low BMI increases SAMs, so the statin-associated muscle symptoms. I think it's probably just that if people have less muscle mass, that if there is something that is a side effect in the area, that they just have more opportunity because their little mass can be affected. I think it probably is related to that. But Bruce or MK or Salman, any
Volume of distribution, Joe.
That could be a volume of distribution thing too, yeah.
It really is.
Higher
Like, I really think that's
concentration
what it
because
is.
of smaller
Exactly what you
concentration,
said.
right? The
Yeah.
higher concentration of the drug because of smaller volume. Yeah, that could
Exactly. You know what I'm finding more and more as we're getting into the incretin space, GLP-1, GIPs, and weights coming down. I'm finding patients are much more sensitive to many, many medications, ones that I wouldn't necessarily have thought were weight-based dosing. So I think it plays a lot into exactly the pharmacokinetics, into the volume of distribution and drug weight disparities there.
Yeah, and this as we're waiting to this too, just I wanted to get some of the questions addressed a little bit. What was chosen was atorvastatin 20, and what would you expect it to do as far, and not every day, but intermittent dosing? How much of a reduction in LDL would you expect? I'd expect less than 30%, but in the 20s.
Yeah, same.
Yeah.
Same.
Every little bit is better than nothing. So something. And we'd have to, right, to go back to your slide, Joe, we'd have to actually test to make sure, because what we'd expect may not necessarily be what presents.
And sometimes a really astute comment by somebody in the chat is when patients are taking their statin, they underperform, they have an under response. It could be because they have high LPA. And that is really possible. This person, and not that we have that presentation in this patient, but this patient did have an elevated LPA value. That's one of the reasons maybe why we're liking a PCSK9 inhibitor. And then too.
Absolutely.
No, I-
Absolutely.
Polyvascular disease. I mean,
I
this
think
is
that's
a
a great
vascular
point,
pattern.
Joe, right? Because statins obviously don't reduce Lp(a), and everything they increase it to a small amount. But if we're looking at maybe 20% of the population has an elevated Lp(a), I still don't think that accounts for the 50% that didn't respond in the manner that we expected for a high intensity statin, right? So I definitely think it's a contributor. But um, I always look at it, what are we inhibiting with a statin? It's an enzyme, right? And we can only inhibit it to a certain degree. So there's going to be a wide variability in response to that as well. Let's get back, to the audience response question here. We had the majority state looking into financial assistance programs such as a foundation or manufacturer. So ways to get the evolocumab free or reduced charge for our Medicare patient. Next most was start ezetimibe and bempedoic acid, which definitely could be an option. No to that bempedoic acid is a branded medication, so that is going to also induce probably some cost complications as well. The first one, bill a copay card with insurance. Why would this may be a problem for our Medicare patient? You don't want to
Yeah,
Not possible.
yeah, you can't. This is me. This is access. This is what I do. I love this. So I'm going to geek out for just a small minute. Just bear with me, everyone. So Medicare insurance does not allow you to use a manufacturer copay card. By law, that is considered an inducement to get the patient a branded drug or from a manufacturer, and that is not allowed. So you cannot bill a copay card with Medicare insurance. I am so proud that people know that there are foundations out there that can do this. So the way around that is that manufacturers will donate to a foundation, which will host a disease state specific grant program. Those grant programs are specifically for CMS patients. So Medicaid patients generally don't need them. So it's more Medicare patients. But again, those are disease state specific. They open and close throughout the year. There's about 4 of them out there. And so it can be open one day and it can be closed the next. Great resource if the only problem patients are having is with one disease state.
Okay, can you share what ones you use for the audience?
Yeah, so we use the HealthWell Foundation, we use Good Days, we use PAN Foundation, and PATH, which is the Patient Access Foundation. So those are the 4.
I'll put those in the chat.
Thank you. Social Security Extra Help is kind of the gold standard when you have a patient that is having issues affording their medications. So that is literally extra help. So it's through the Social Security Administration. It will cap a patient's co-payments based on whatever it is for the year. So it's about $13 this year for branded medications, and then it's lower for generic medications. You have to be, depending on where you live, fairly low income. So the cutoff is about 150 to 200% of the federal poverty level. Again, that is dependent on the state that you live in. But then they tier it after that. So you can be 200%, but you may not be 100% extra help. So it could be a little bit different. That eliminates or very much shrinks the donut hole for patients. And it also limits or eliminates their deductible at the beginning of the year. So if you have patients that are, like you mentioned, on a GLP-1 and on a PCSK9 and they're on Entresto and they're on all these things, my preference is always just to see if they can qualify for extra help. It's also called a low-income subsidy sometimes. They can literally just call the Social Security Administration, ask to be evaluated. They can also go in person, but that sounds horrible, or you can apply online. But those are good ones. Like you mentioned, ezetimibe bempedoic acid is also branded. I think that would, again, maybe a challenge for the patient. And then you could absolutely start inclisiran. So inclisiran is another option, which is billed through the medical benefit. So some patients, and again, foundation assistance can be applied to medical benefits as well. So thinking through what the best option for the patient is and how you can get it, because drugs don't work if you can't get them in their hand. Doesn't matter what we pick if patient can't actually get it from the pharmacy or inject it in the clinic.
And there's, I don't know if it's a loophole or how you want to call it, but for inclisiran specifically, when it's billed under the medical insurance, if they have a supplement with that,
yes,
there's usually no prior authorization and there's usually no charge to the patient. So that is one avenue where, just like this case is presenting, we want to get them on novel lipid-lowering therapy. That is one caveat where some patients will qualify for that and there not be the financial burden.
Absolutely. Okay. Here we go. So these are the other options that the patient had, just like Joe and Bruce mentioned. In this patient in particular, Salman, why did we pick evolocumab for her?
I think we were trying to target also lowering the lipoprotein A for the patient, as well as, she had polyvascular disease. She was willing to try it on her own at home. So that was something we kind of wanted to, empower the patient to be able to do that too. So that's kind of why we went down that direction. We did give her the option of inclisiran, but she really wanted to do it at home and didn't want to come into the clinic all the time. So
Do you guys find that your patients want to come in every 6 months, or do you find that they want to do it at home? I feel like mine's 50-50.
50-50, yeah.
Pretty
I
close.
found more patients wanted it at home, just because what we use is based in the hospital. So it's, it's going to the campus. So maybe it might be where our injection site is. But educating patients on how to use injectable meds has never been easier. I mean, these pens never been easier. I think there always, for some people, there are barriers. My sister-in-law is deathly afraid of needles, though she wants Ozempic, and she won't do it. And I try to explain to her how easy it is. And most of the times I'm successful, but you're not always going to be successful. Some people that, they want to inject it for them, and other people are like, sure, there's this great, I guess, acceptance now of injectable treatments. Maybe that's the GLP-1 effect.
Yeah,
But also it's because they're easy. The pens have been
So
made
easy.
very easy. Go ahead, Bruce.
I was going to say I saw the acceptance of injectable therapies well before kind of the mass rise in incretin therapy use. But yeah, because the pen dynamics are very easy to use.
Yeah.
And actually, I was going to chime in and say, how many of you actually have patients who refuse to start any of the PCSK9 modalities because of an injection issue? Is that
We do until we show them the demo pen. And then they're like, oh, yeah, I can do
that's
that.
the key, right? Like after you've done your counseling and teaching,
Yep.
that's a question. Even at that point, do you have patients? I could probably count on one hand in our clinic and for patients that's occurred. So,
And there's great videos too that make people feel better too. Real simple.
think back to insulin days. Right?
Oh, when they had to drop the dose.
Yeah,
much different. Or it really going way back before our times where we used glass needles. And people have to sharpen their. Yeah, I mean, there's probably some people in the audience that remember that. It's before my time, but it used to be a lot worse.
Yes.
Or
It is a lot easier
Bydureon.
now. It is a lot easier. I do find that also kind of once we go over the mechanism of them, like you were talking about before, Bruce, once you go over the mechanism, most people are very accepting of monoclonal antibody therapy and especially if they've had intolerance in the past, maybe even more than trying another cholesterol pill, as they call it, because at least that's how I feel like we get a lot of buy-in on injectable therapies. It is targeted. It is doing what your body already does and making sure that you explain it, just like you said, Joe, earlier, in patient language. That is something that, we as pharmacists spend a long time learning about how to kind of translate this into the patient space and into that language. How do you kind of convince your patients? I won't say convince. How do you help them and educate them?
To take this kind of product or an injection? I'll tell you a little bit about with PCSK9s. One thing that I have shared with patients is, because they've heard about statins, and I try to use patient-friendly language in sixth grade level explanations. Oh, this helps your body make less cholesterol. Well, when I talk about PCSK9s, I'm like, this helps your body remove cholesterol. I say it's capitalizing, it's sort of enhancing a natural function, which is those LDL clearance receptors, and we know statins do that too to some extent. But the PCSK9s, I think sometimes when patients hear about the mechanism of action, if they can sort of tie it to something that normally should occur, there's sort of a better feeling. That's why when we have drugs that are hard to explain, maybe, people go to the internet and they get confused and they're thinking it's like too much of a chemical. And then they hear dis and misinformation from people with titles in our government that don't know what they're talking about, and they get confused and they get afraid. But if we can really, try to never always be honest and try to like explain it in something that seems appropriate for your patient, then you can always try. And when you do that, I often have success, not 100% of the time, but often.
I agree. I think hanging my hat on, this is something your body already makes. This is something that your body already does. And we're just making sure that your body does it better.
Yep. We're getting rid of that I call the PCSK9 appendix. We don't need it. It's flaring up. And some people tell me when I've said that we do need an appendix and whatever. I'm like, whatever. Just get rid of the PCSK9. It's an interloper that causes problems.
Those are all great thoughts, and I utilize all that as well. And I think that does resonate a lot with patients. A natural type of mechanism. It's not some synthetic foreign product your body's never seen. The other thing that I do bring up too is drug-drug interactions. Like how many drug-drug interactions do you see with monoclonal antibodies? And the answer is none, because their metabolism is very, very different, right? They don't go through the same biotransformation pathways. And I would say that's probably the majority of where a lot of statin intolerance comes from, or escalating plasma concentrations. I get this question a lot from our seniors, can I drink grapefruit juice with my statins? That comes up so much. What is your response to that?
My
How much
response
do you
is,
drink?
do you actually drink grapefruit juice, or you just heard
They
that
love it.
and now
They
you
love it.
think that's
Or the fruit itself.
I think that, my understanding is it's not the as far as, if there's flavonoids in grapefruit juice. My understanding is through the processing of how they, mass produce grapefruit juice. So it's not the whole fruit, it's the juice concentrate, probably because I think there's something in the pith when they squeeze it that it leaks out some of that. I think there's some unknowns. I've dove into some of the grapefruit juice interactions, and the data are not, it's really muddy waters there.
Yeah.
It's not really the clearest of data, but it seems like you have to have a certain amount. So we're only talking about statins that are 3A4 anyways, even though those,
Exactly.
but then we see that appear on amlodipine, which barely has any 384. So
Oh,
there's a whole bunch of things that people read that come from, product inserts that are written extremely in a conservative manner. But my bottom line is, if you're drinking it every day, you probably shouldn't, especially if you're drinking a cup or more every day. But if you're drinking a cup every once in a while, I don't care, especially if you're on one of the statins that doesn't require 3A4.
Don't drink it for your diabetes either.
Oh, well, don't drink juice at all. Juice has too much sugar anyways. Bruce, you brought up one quick point I just want to expound on. I know we're running out of time, but I also like with these newer drugs, even though there is a cost consideration and prior authorizations, you hit on something that's really important. They're made so smartly and specific that the off-target effects are smaller, which includes side effects and drug-drug interactions, and even contraindications too.
Yeah. They're cleaner drugs. They really are. And with that, we see good tolerability.
Patient comes back to lipid clinic after 3 months, reports taking the evolocumab 140 milligrams sub-Q every 14 days. Last injection was about 5 days ago. LDL today was 68 milligrams per deciliter. So this is another audience response question. What is this patient's LDL goal? Is it less than 100, less than 70, less than 55, or less than 40?
And I'd love to see what people really would choose. Like, if this is your patient, what are you picking?
I would love to make the point, because you did a great job pointing it out, Salman. She took her last dose 5 days ago.
Yes.
So we are very low in her dip, and she's at 68. So just think about, I always try to do, like not actual math, but like back think through. You really want to get the lab right before the next dose, because you want to know what that peak would be for that patient. So again,
The worst scenario, right?
yeah, and you want to know what it's actually the highest that it's going to get.
It's like most every 3/4 of the audience went with less than 55, about 13% at less than 70, and same for less than 40.
Yeah.
So I'd say that's probably consistent with how we would think. And it depends on what guideline you're following. But the contemporary US ones are going to be less than 55 for this particular patient.
And what scares me about this patient is that, they've had multiple forms of clinical ASCVD, and they're on isosorbitine mononitrate, was it? So they must have angina pain. That scares me.
Kidney pain, angina pain.
That's why they cath, right? Ooh.
A lot of atherosclerosis there. So high-risk patient.
These are the ones that apply to our patient.
So what lipid-lowering medication would you potentially start to target that LDL goal of less than 55? Would you start ezetimibe, icosapent ethyl, bempedoic acid, fenofibrate, or ezetimibe with bempedoic acid?
I would say no wrong answer here either.
Well,
Well,
I don't know. I don't know if I agree with that.
yeah.
Maybe there's a few I don't like,
Right.
Yeah.
but I like your positivity.
There's multiple things you could do.
There is, but there's one or two I don't really like, and nobody picked them.
Okay, good.
So it looks like winners are ezetimibe or the combo ezetimibe and bempedoic acid. No one picked your triglyceride lowering agents, Joe. So there you go.
Good.
You want to
LDL
put them
first,
on
please.
fibrate, Joe?
Take care of LDL first, right? And I think that's audience knows that. Good.
Yes.
I mean, 99 times out of 10, I'm gonna go with ezetimibe because of cost, right? I mean,
Yeah.
in this kind of patient, because at least where I work, bempedoic acid, our prior authorizations often require, not always, but they often require a trial of ezetimibe. So,
Agreed. Any last questions from the chat, fellas?
there were some great ones. You addressed some of them with the grapefruit juice was talked about. There was just a reminder that a sure vitamin D level is normalized. I think it's worthy to check it on this patient. I think that's a great comment here. And we do have a few minutes still left. What is the minimum duration of a statin to be tried before moving on to another? I think this is going to be sort of a judgment call. I think I don't see anything defined, but what what do you guys think on our
I
panel?
think the patient oftentimes decides for themselves what they think that is. I have patients who literally have tried one dose and they're like, nope, I had a leg cramp that night, I'm done. Which we then talk about, okay, that's not enough time. I traditionally, again, from the pharmacokinetic side of it, am thinking about a week because you're going to get them to steady state around a week, a little bit less than. So if we can get you to try it and hang with me for a good week or two, then we can really see what happens is generally what I talk to patients about.
There's
All right.
a lot of good
So,
questions here. Go ahead.
the tremendous number of questions here. You guys did a great job, and I want to thank our audience for tuning in tonight. Thank Bruce and Mary Catherine and Joe and Hasham, everybody, for doing a great job. There's CME associated with tonight's presentation. I want to remind everybody that our last lipid panel before the summer is June 24th, when we're going to have a great panel with Donald Lloyd Jones talking about prevention calculators, and associated case presentation. So hopefully everybody can tune in on June 24th for our next lipid panel. And again, thank everyone for their contribution tonight. Outstanding panel, and thank the audience. Have a great Memorial Day weekend.